Hello, I'm Norman Swan. Welcome to this program on maintaining well-being, depression and anxiety in men with prostate cancer and their partners. Prostate cancer is the most common cancer in Australian men apart from non-melanotic skin cancer. 1 in 9 will develop the illness in their lifetime. Men with prostate cancer report higher levels of depression than the general community, but the rate of depression and anxiety in their partners is even greater, more than double the incidence of the Australian community. However, psychological distress and depression in men with prostate cancer and their partners is often overlooked and underdiagnosed. And there's a fair bit of evidence that cancer-associated depression has its own issues, and that's what we're going to explore tonight. You'll also find useful resources available on the Rural Health Education Foundation's website, rhef.com.au. You're not allowed to go there just yet because you've got to meet our panel. Suzanne Chambers is Director of Research at the Cancer Council Queensland and Professor of Psycho-Oncology at Griffith University. Welcome, Suzanne.
Thank you, Norman.
Suzanne's a member of the Australian Cancer Network Working Party for the development of clinical practice guidelines for the management of advanced prostate cancer. And as you hear, that's associated with very significant psychological morbidity. Caroline Johnson is a general practitioner and a lecturer at the University of Melbourne. Welcome, Caroline. Caroline is about to complete her PhD, which is on monitoring depression in general practice. Peter Strange is a nurse practitioner specialising in men's health within the rural Bendigo area. Welcome, Peter.
Good evening.
So you do mobile clinics, don't you?
We do go to workplaces and out to areas where there aren't doctors, yeah.
And what sort of things do you do?
We do health assessments for men, and particularly we're looking at preventative health sort of medicine as well. So getting to the guys that won't come and see their doctors.
Right, so you're involved in the men's shed movement and stuff like that?
Men's shed movement, anywhere where we can get to men, yeah,
right.
For preventative type health we're interested in.
Yeah, getting close to too much information, but yeah, no, that's good. Colin Bartlett is a prostate cancer survivor and also suffered depression through his illness, as you're about to hear. He's also a facilitator for the Westmead Hospital Prostate Cancer Support Group in Sydney and also is heavily involved in the Prostate Cancer Foundation. Welcome, Colin.
Good evening, Norman.
And welcome to you all. Colin, tell me your story.
I was asked to have a PSA test by my doctor under protest. I had it done. 4 days later he says, we have a problem. We have a problem. I had the problem. Go to a urologist, and I was given a DRE and promptly told there's an irregularity, we're going to have to go to another stage. At that time it didn't really come home, but the next bit did, having had a...
You didn't realise you were on a truck hurtling towards the wall?
No, I didn't. I then went to have a biopsy done, and it was after the biopsy that the world crashed. And that was when Trish was with me, my wife, and Andrew just told us straight away, you have cancer. What are you going to do about it? Shock, horror. I think she was more devastated than I was, but the mind just goes into free fall. What am I going to do?
Can you remember the emotion attached to that?
The emotion is one of disbelief. You know, why me? Why has this happened to me? And I think a little bit of faith came into it, because I just then turned to him and said, look, I'm going to make sure other men don't fall into the same trap that I've fallen into. And that's all I could say at that stage.
So you were obviously offered a series of options?
Yes, I was given 3 options, and the 3 options, just given them straight out, which is a radical prostatectomy, of radiation therapy, or we could possibly go on to some therapy if it suited. And that was just left at that, and I was to make the choice.
How did you make the choice?
Seeing as the urologist wasn't much help, I did get a piece of paper that indicated a prostate cancer support group at Westmead Hospital, and I phoned the guy up who was the facilitator, who still is, by the way, and he gave me some information about choices, and I went to see him and we talked about it, and yes, we decided really there was no option but a radical prostatectomy, because the Gleason score was high, 7, the PSA was 20, and it meant I really had nowhere else to go.
Yeah. When did the depression hit?
That, Norman, is an unknown factor. I don't really know when it really hit, but it's been an insidious thing that's been growing and growing and growing. And possibly I think it really came home probably about 3 to 4 months after everything I thought had settled down, and it hadn't.
So you had the operation. How did it leave you?
I felt pretty good, actually. I wasn't particularly worried. I didn't have any pain or anything like that, but I just didn't feel, I was still in this free fall. What am I going to do? And I didn't really know what I was going to do.
So you
didn't know what to expect either.
And were you angry? Were you feeling anxiety? And
I was anxious, of course I was. Very anxious about how Trish was feeling. She was my main concern.
how was it going between you?
Then, very good. We were pretty good. We'd suffered a few other little problems which had brought us, I think, a bit closer together. So we were in a fortunate position at that stage, but it unwound later. It unwound later on.
Unwound.
I'm afraid I was the one who was the problem, because I virtually shut off. What you feel is pain, and it's a pain that's a mental pain. And how do you run away from it? How do you get away from it? I found solace in getting on my bicycle and going off and doing 3 or 4 hours ride and coming home, and because I was...
The male thing of riding off into the sunset.
Virtually, yes, Norman. Into the sunrise, actually, at that time of day when I'm around. Yes, that was... You sort of get yourself into your own little sphere, into your own little bubble.
So she wasn't able to make contact with you?
We didn't talk much about it, no. I had a lot of men come to talk to me. I had a lot of support from the support group itself, and it more or less put her out on a limb. She really didn't do much in that course at all.
And how did it get better?
I think it got better once we had got rid of continence problem. I suffered a post-operative hernia, and we had that fixed. And after that, things started to get back into a normal operation, but for one thing. I had continence troubles. I had incontinence. It wasn't bad, but it was enough to cause us some concern, and erectional dysfunction had also gone.
Did anybody recognise the depression?
No. That's the terrible thing about it, because I never talked to anyone about it, and I didn't see what was happening to me. I didn't know what was happening to me.
So how did the depression show itself in you? What sort of...
The depression showed probably after about 3 to 4 years, starting to get very snappy, very irritable, and being a bit picky with Trish. I look back at it, I'm ashamed of some of the things I said to her, because I don't have to drive with you, do I? And I started getting very critical about her driving the car, and I didn't notice it. I was just picked up as a grumpy old man who'd had a prostate operation.
Were you sleeping?
No, not very well at all, no.
And had you lost interest in things around you?
Yes, complete.
Had you thought of killing yourself?
No, that didn't come into it, no. I didn't. There's no self-harm in me. I'm very, very firm about that. There's no self-harm.
But you ended up not getting treated for it?
Quite a long time. As a matter of fact, it's only after, say, 6 years of going through this that I finally was recognised as having a problem. And that was going to a men's shed function and listening to somebody talk about depression. And his recommendation was then, go and talk to your GP. You do have a good one? I said, yes, I do. I'd known him for 20 years. And he said, he will be the best person to see. He knows an awful lot about you. And when I did go to Jim, he said, well, more or less, I've been waiting for you to come.
But hadn't asked?
But hadn't asked. So, in a way, that's a bit disappointing, but I won't hold it against him, because obviously we're on the right track now. We have found the way through, and having a good life. There's been a spin-off. I've been onto medication, and it's quite a new story. The medication, I started in September '09, and by December '09 I'm beginning to say, where's this continence problem gone?
So a few things have been fixed up in one hit.
And it's just gone. I'm the same as you would be, the same as any man who has not had a prostatectomy, which is quite surprising. And asking then a beyond blue person what had happened, she said straight away, what medication are you on? And it's a serotonin type of medication. And she said, well, are you thinking about it anymore? And I said, no, I hadn't thought about it now. She said, well, stress continence, it's gone.
Peter, you're nodding sagely there. This is obviously not an unusual story for you.
No, I'm very interested in your story, particularly connecting with the actual discovery for perhaps early diagnosis of depression was at the Men in Sheds.
Well, it wasn't early, 5 years, 6
yeah,
years.
That's true, but I guess
the first diagnosis.
The first diagnosis, and that it's interesting that the community groups and support groups and people that you just have a chat to that often will pick up these things. So, and I think it's really important point to get across right from the word go that I think clinicians need to ask how people are travelling, if it's as simple as that. And that's probably what you needed, Colin,
yes,
for someone to put their nose in a little bit and give them opportunity to have a listen.
Now, you'll see men with psychological issues, particularly depression and anxiety, a lot. Is it different when men have cancer? And is it different when men have prostate cancer?
I think it is. I think perhaps the more extreme, the morbidity or the condition, sometimes I think men can bury it more, so it's even hard to get out, but it does become more extreme. I don't know that it's...
Sorry, when you say more extreme, you mean what?
The cause of perhaps the depression, So I guess the medical condition will determine that and how they perceive the medical condition. And I think that's important. So if we can help them through, give them education and explanation, then perhaps we can lessen that. The waiting game for waiting for tests, not understanding.
And also it interferes with your sense of your own masculinity.
Absolutely, yeah. I think men will race ahead, so that we might start as medical professionals say, look, we're having a test, we're having a PSA test. This may not mean anything, and then I think some men will automatically race ahead right to, gee, I'm going to have cancer, I'm going to have erectile dysfunction, I'm going to have this, I'm going to have marriage problems, and all those sorts of things. And I think as clinicians we need to think about that, perhaps help where we can.
It may not be unrealistic.
No, I agree. I agree.
Caroline, a familiar story from your point of view as a general practitioner interested in depression?
Oh, it is indeed. I think it's, I think one of the biggest tricks for GPs is getting this balance between the physical and the psychological. So if someone comes in with a cancer diagnosis, we assume, and probably rightly, that the biggest thing on their mind is this something that's going to kill me? And so we focus on the physical. And we often will say questions like, how are you travelling and how's it going and how are you coping? And we think that's us, screening for depression, but patients often hear that and think we're saying, how are you coping with the cancer? So sometimes, you're right, we do have to be a little bit more specific with the questions.
A bit more systematic, perhaps.
Well, yeah, that's an interesting point. I mean, there aren't many, research trials that show that by introducing systematic screening, you might pick up more cases of depression, but whether you'll actually get to better outcomes is a bit more controversial, unless you actually do something.
Well, hard to get to better outcomes unless you actually find out somebody who's got depression.
Well, that's true, but if you just ask, certainly, in the late 90s there were lots of studies that showed that if you ask people, are you depressed, and they say yes, it doesn't necessarily mean that anything will get done. So I guess it's important just to emphasise that if you're going to ask the question, you need to have some kind of plan in place of what to do next.
Suzanne, how could it have been different?
Well, I guess the first thing I would say is that the story that we've heard is just very typical, I think, of how men often present when they're distressed and have depression, for example, after cancer, that being withdrawn, being angry, strain on the relationship, and that it does get put down to just being a cranky old man, which is quite untrue. The other thing I would say is that what we do know, we know there is a range of risk factors that are predictive of someone who's more likely to suffer distress. They're things like lower levels of education, being poor, having a previous psychiatric or history of depression is very important. Stage of disease and symptomatology can be important as well. But the one thing that if you measure at diagnosis, the level of distress, that's the biggest predictor of subsequent distress. So I guess what I would say is that if someone had been keeping a close eye on your levels of distress from the beginning, probably would have picked up that they were pretty high and then might have been able to get in early. Because in essence what you had was a prolonged period of suffering that was unnecessary.
Yes.
And those are years that you can't get back in that sense. You know,
Yes.
you've done well and it's great now, but that's, you know, not a good thing that went on for that long. The other thing is if you think about it, there are like three main components to think about with a cancer-specific distress. There's the psychological aspect, which is the distress that the man exhibits, whether he's depressed or anxious, those sorts of things, having intrusive thoughts. Then there's the social context, which is what's his relationship like with his partner? Is that a supportive relationship? Has that relationship been there for a long time, and is it like a well of resource for him? And then the third thing is what's happened with the cancer itself. You know, how has the treatment worked out? What's the symptom profile like? And I think when treating a cancer-related distress, you've got to treat all those things. Very important that you also treat the side effects and symptoms of the cancer treatment, because otherwise the intervention just doesn't look relevant to the man who's primarily identifying I've got cancer as his presenting problem.
I think one of the greatest problems, Norman, that we face within the support group is one, continence. Incontinence is a big problem, and to a degree a lot of people don't seem to notice it or recognise it. We're focusing on it at the moment, excuse me, to bring a little bit of awareness to the guys who are in the support group, to know that there is something there to help them, because you know, a lot of them suffer greatly with continence problems.
And it's pretty depressing.
Very much so.
Which is your point.
That's exactly right. You can't divorce those physical things away from the psychological impact. When they do unmet supportive care needs surveys of men with prostate cancer, the big ones that come out are unmet psychological needs with regards to fear of cancer recurrence and unmet sexuality needs. And so I guess for my money, if I were going to pick something, I'd focus on those would be the two aspects for men who are surviving prostate cancer.
Do you think you've got the equipment to ask the questions, Caroline?
For psychological things?
Well, to explore this?
Well, I think everybody has a different style. I certainly think if you make it part of your routine practice to raise the issue that we know that when you have a serious illness, it can be psychologically distressing, that these are some questions that I'm going to ask, and is that okay with you if I ask them? So that people kind of know that you're not just running through a checklist.
So give us the script that you because it's often useful for GPs to hear the script that the experts use. What about some of these questions that you might feel awkward about?
Well, the screening tools that we use as psychologists are a little different to what works in general practice. So I'll say what I would do, and then I guess I'll flick to Carolyn and defer to her. We typically use the distress thermometer, which is a single item, and I'll often say to people, look, I'm going to ask you a question that sounds a little bit strange. Probably no one's asked you this before, but it's really just to check that I understand where you're at and I'm not missing anything. So on a scale of 0 to 10, where 10 is really high distress and 0 is I'm just fine.
And you use the word distress?
Yeah, I use the word distress. Where would you see yourself? And then they'll give me a number, and if it's less than 4, I think they're doing okay. If it's over 4 or 5, then there's a good chance they've got some anxiety or depression there. And it's over 7 or 8, I'm very concerned about them. And so that helps guide how much I will go into in depth with that person about their psychological condition. But what I always do is let a person set their agenda first with me by saying, tell me about what's been happening to you and why it is that you've come to me and what it is you'd like me to help you with, and then weave it into the conversation. But I'm interested, Caroline.
But that's in a referral situation with the
That's
GPs in the
right.
first
Yeah,
situation.
that's
Well,
right.
I mean, I have to say I heard that technique just tonight, and I think it's a great technique. We do it all the time for pain. When people come in with pain, we say on a scale of 0 to 10, where would you rate this pain? It makes perfect sense to do that, and it is a non-labelled way of raising distress.
And just psychic pain.
That's right. And I mean, if we're talking specifically about depression, I still think the Hooley questions are good. In the last 2 weeks or in the last month, have you been bothered, sad, feeling down most of the time? Have you lost interest and pleasure? And some researchers in New Zealand did a trial where they added the question, and would you like some help with that? No, yes, or yes, but not today. And they found that extra question was a really good way of picking out the people that might actually have been a false positive, which kind of helps you a bit. If you ask people, would you like help, and they say yes, it should ring a little bell that they're the ones you really should be focusing on doing something for.
Could something have been done at the diagnostic stage? I mean, for example, one of the better predictors of whether or not you're going to regain erectile function is how much erectile function you had before, and regardless of your age. Could things have been done with Colin earlier? Is there any evidence of preventability?
Well, I think there is evidence of preventability. I guess what I think is important is that at the outset, that people understand this is going to be psychologically tough. It validates then, if you start feeling distressed, you're not thinking, I'm weak, there's something wrong with me. So saying, this is a tough experience, let me give you some tips about things you can do to help yourself. And ideally you work with both the man and his partner, because the best thing you can do is get them working as a team and try and preempt relationship issues, which are not uncommon after a diagnosis of prostate cancer.
Because I think David Bentovian's research in South Australia showed that much as men don't like expressing their distress, women don't like expressing it either, because they feel they have to be the rock in this time of turbulence.
That's right. Women are often sort of the emotional sponge in a relationship, so they take on responsibility for maintaining some sort of emotional balance, and they suck it all up. So while you're getting cranky and irritable, she's just sucking it up and just feeling worse and worse. And often men and women have different communication patterns about dealing with difficulties, so if you can help them negotiate a way to do that that makes each person feel validated, I think that's really important. It's important that people know that tough times are ahead, and that they give a hint of, if you start feeling this way and it goes on, it's normal to feel distress, but if this goes on for some time, there's no badges for bravery. You go back and see your GP, or you call someone and you get some help early.
Peter?
Yeah, and I think we may need to ask more than once, so that we may be asking, someone like Colin, how he's going, how he's feeling, and at that stage of the process, and this is stretched out over 5 or 6 years, he may be doing well. So we need to keep on asking him, how he's travelling, and ask him those important questions, because there'll be different periods where he goes up and down. And
how important do you think setting expectations are right at the beginning, so people know the journey they're going to go on?
I think we need to be very honest. I think we need to keep it very simple, because men that certainly are having stresses won't be able to take in a lot of information, educational, but I think we need to be very honest. But we can't obviously predict what's going to happen, but these are the possibilities.
Colin, in retrospect, what do you think could have been done for you at that diagnostic stage, before anyone had laid a hand on you or a knife on you, that would have made a difference?
I think one of the things that would make a difference is having what we call a roadmap laid down of what's going to be, what the expectations are, what's going to happen.
Well, physically and psychologically?
Physically and psychologically, yes. And I think the psychological one would have been very, very important, because I didn't realise that was going to happen. And I think that's been the most devastating part of the whole deal, is the psychological part. We're sort of out of it, but it's still, it's still a devastating thing, the psychological bit.
And in country towns, it is going to be the GP who will carry the burden of that.
Well, I think that's true. I mean, I think there are more opportunities now for GPs to get support, but it is harder in the rural setting because there are less health professionals. I mean, it's great that there are nurse practitioners now who are available. Some practices have mental health nurses now in their practice that can help them, particularly for people with more serious, psychiatric illness. There's also telephone support for GPs through, GP psych support. But ultimately, the GP is the person who's often seeing both partners in a relationship like this, and so they often get the warning signs earlier. And it's just knowing how to act on that is the challenge.
And Suzanne, as the journey progresses, because things like hormone treatment can be pretty rough psychologically.
That's right. I mean, I think it's important to recognise it is a journey, and distress is typically very high at diagnosis, usually quite rapidly diminishes, but then can spike when there are critical events that happen, which might be, for example, a cancer recurrence, where distress can even be higher than at the initial diagnosis. If a man is diagnosed with recurrent cancer, he's at some point going to be put on some type of hormone treatment. And hormone treatments have quite serious side effects, such as mood disturbance, cognitive changes, changes in muscle mass, central adiposity developing, osteoporosis, libido goes, erectile dysfunction. There's some very good work being done in Western Australia on using high intensity exercise to help with that. So there are things that can be done that are I guess, complementary therapies in a way, but serious exercise physiology work, and there's Medicare rebates I think for that as well, with exercise physiology under certain plans. But again, I guess for the GP, it's being aware that things change over time for men, and so every time you see them is an opportunity to check about how things are with the prostate cancer and what's happening there.
Well, let's go to our case study and work through some of these issues through our case study. Don's a 52-year-old farmer. He comes to his GP, to Caroline, with urinary symptoms, and certainly when you do a digital examination, it feels a bit odd, and his PSA comes back at 7, and you refer him for a biopsy because his brother was diagnosed with prostate cancer, which is in fact why he did the PSA and DRA. He was widowed 4 years ago and got a bit depressed. He was wiped out of breast cancer after many years of illness. And luckily he's recently repartnered. Caroline, what's your approach going to be towards Don? He's got the risk factors.
Well, that's right, he does. And I mean, I think, first of all, any time you do a test that's a test for cancer, you should try and discuss with the person, before you do the test, what the possible outcomes would be, because you don't really want to have that situation of ringing someone and saying the test is abnormal and them getting very distressed and panicking before they can hear what it really means. So I try and tell people beforehand what the possible outcomes, without going into a lot of detail, and then obviously when the test comes back that there is concern that this could be cancer, then taking into account that he has got risk factors, he's got a past history, he's also had experience of cancer through his brother and his wife, and I think that might, alter his perception of what that might mean. He has some existing knowledge, but it might be helpful or unhelpful knowledge, if you like. So finding a bit about
Peter,
that.
you might want to know what happened to his brother to see what framing he's got.
Absolutely, it's going to be significant, certainly. So we should be thinking, I think the bell should be ringing straight away when you're presented with that sort of history, and start asking the questions about his brother and how he feels and how close and how much that's affected him, because that's going to drive him certainly into that condition of perhaps early depression.
So, Suzanne, is there anything that you can do at this point to steel belt him apart from what we've been talking about in terms of improving his psychological resilience?
Well, I think the things that I've already mentioned are entirely appropriate for this person. I guess close surveillance, and I think what Peter said, you've got to find out what's the picture he's got in his head about what a prostate cancer diagnosis means. It may be that he's actually more focused on what happened to his wife, and he's applying that, that she died a difficult death, and that might happen to me. Or it could be focused on what happened to his brother. But you don't know until you ask those questions. You get a bit of a picture. You can, if he's got lay beliefs about cancer that are unhelpful or untrue, you can start to try and correct those. Just keep a close track on him. He's in a new relationship, so he doesn't have a 25-year history of experience of coping together through adversity. So that couple, I would anticipate that they would need some support and perhaps some relationship counselling for. This is going to be a tough experience. It happens to you as a couple. Let's talk about the things you can do to support each other through this experience.
I was going to say also the fact that he's got the history of depression, and in a way it sort of rings bells that he's more at risk of depression again, but you can use that to your advantage by saying, well, what was it like when you had depression last time? What were the symptoms that you experienced?
What would you do for him if you did a screening tool on him and found he was depressed?
I would ask him what worked for him last time, and if he had antidepressants last time and they were very effective and he had very similar symptoms this time, I'd have no hesitation in suggesting that he try them again.
But Suzanne, the evidence is it not, that antidepressants don't make an awful lot of difference, mild to moderate end of the scale. And cognitive behavioural therapy is the thing that will actually improve their resilience. In other words, the only thing that improves your resilience in terms of reducing recurrence is psychotherapy, isn't it?
I don't know that I would agree with that. I think a combined approach is appropriate and individually tailored, because you can look at studies but then you look at individuals. So, I mean, I'm with Carolyn on this. I'd be looking at what did he do that worked last time. I do think, though, that trying to help people develop adaptive coping strategies if their predominant coping strategies have been unhelpful to them is part of it as well, and that's maybe that's part of trying to build their resilience to move forward.
And coming back to Colin's point of information being important, what evidence is there that information has an antidepressant effect?
I don't know of evidence that information alone has an antidepressive effect, but I think it's just a basic thing that you need information that you can understand so that you can make difficult decisions and live with the consequences. I think it's just basic good care, really. The difficulty for people diagnosed with prostate cancer is no one with cancer expects to get a choice. I don't know how many times I've had men say to me, what's this business of there's a choice, and one of them is I don't do anything, which is their observation.
Well, that's what it's going to come to. I mean, Don comes back to the GP because he's had the bad news from the urologist. The urologist says, look, there's no rush here. You go off and think about it. You can have a radical, you can have 2 different types of radiation, or we can just watch and wait for a couple of years and see what happens to your PSA level. It's only 7 at the moment. We can watch it. You know, you're not going to die if we wait for a year or so. And he goes home. He's miserable, angry, and he's dragged in by his partner to see you, Caroline. And how are you? And he wants. She says he needs help to make a decision. You know, sit down, Don, and listen to the doctor.
Well, I think in this situation it is hard because, you know, we as GPs, we often draw on, you know, experience from previous patients or experience that we, you know, stories we've heard, but really what we have to do is empower the patient to make a decision using the information they've been given. And one thing that has been tested in general practice is to use problem-solving therapy, which really we work.
How does that work?
Well, you work with the patient to generate a list of the problems. Now, in this case, it might be just as simple as choosing which therapy, but you really have to try and work with the patient to try and generate as many problems that might be associated with that as possible.
So there's no cognitive restructuring involved?
No,
it's
a very structured approach, and there you can actually, you know, download structured problem-solving worksheets off the internet if you're so inclined. It's not a difficult technique to learn, but it's really just guiding the patient through that decision-making process, trying to generate as many solutions as possible, or then listing them and working out the pros and cons of each one. And it is quite an effective therapy, but it's one of those ones that, you know, you probably shouldn't. It's probably a hard case to start with. If you wanted to have a go at problem-solving therapy, you might not choose a distressed man with prostate cancer as your first subject for trying this therapy. Try it out on yourself, or perhaps on a more simple case, and then if it works, then you'll get the confidence to try it out with someone like this man.
If there's more than, also I think one of the problems, if there's more than one clinician involved, then we really need to try and get our stories together or communicate, because that can create more confusion for the patient. If we're getting even slightly different stories, we really need to do that, I think, on behalf of the patient. So otherwise it's going to become very confusing.
A nurse in northern Queensland asks, are there any antidepressant medications that are contraindicated with prostate cancer?
Well, I'd usually start with the antidepressants that I'm used to using, and I'd usually use ones that didn't interfere with urine function. I don't know if there's a strong evidence base for that, but I'd probably start with SSRIs rather than tricyclics, because tricyclics have, you know, urine symptoms. Yeah. And of the SSRIs, I think the message I get from the experts is that they're pretty much all in the same bunch, but some of them have, you know, slightly different advantages. Some doctors...
Well, and they do have sexual side effects.
Well, that's true, but I mean, I guess that's going to be a problem really with all of the antidepressants. It's going to be a problem with the treatment. I think you have to make a decision of how severe the symptoms are. And also, again, if someone's had these treatments before and they've worked, that's a very reliable indicator that they'll work again, at least worth trying.
The same nurse in Queensland asks, should all men on hormone treatment be automatically prescribed antidepressant medication? I
certainly wouldn't do that, but I can't see any reason why you would, especially not if they weren't having those specific side effects. I don't think you would. I think you'd do it based on the severity of their symptoms and also their preference.
A question from Western Australia. It's a while since we had a question from Western Australia, so thank you very much for that question. Also a nurse. Is there any information on suicide rates in patients diagnosed with prostate cancer?
The only one that I'm aware of is there was a paper published recently, and I've got a feeling it was European data, which showed an increase, I think, in the relative risk of suicide in men with advanced prostate cancer. But I think, and I certainly, to be honest, I've certainly, you know, had experience of men with advanced prostate cancer committing suicide, and it's something you certainly never forget. But I don't have the exact data on that. And I guess, though, the main point is it's more about anybody who's got depression needs to be screened for suicidality. You just got to, you know, make that call.
You just got to ask the question.
You've just got to ask that question.
Do you ask the question, Peter?
Certainly do. It's obviously not the first question, but I always, certainly if they've got mild, moderate, or I think they've got mild and moderate depression, I always ask that question whether there's any self-harm. And
given that you're seeing men in men's situations, how do you involve the partner? Because they've got to be involved.
It's interesting, sometimes the man comes in because of the partner in the first place. So the partner may be involved from the word go.
You just don't necessarily see them straight up.
It can be, but I think that's a question we also ask. You know, how you're travelling, how your partner's travelling, and then I often go into the relationship and ask them how he perceives the relationship is. And then if the discussion wants to go on from there, then I offer that we see would there be a benefit of seeing you both together? And I think that's a really positive move, and particularly if he agrees to that, that there'll be some benefit.
Caroline, do we know to what extent treating the man helps the woman's depression?
Well, I don't think I could answer that. I mean, I mainly see women who are worried about their partners, and I certainly find, you know, talking to them can help them deal with their partner's depression. Like, I can give them sort of generic strategies of...
But the risk factors that Suzanne just spoke about for men would apply to women too. If they've got a previous history of depression and so on, they could be at major risk. Well,
I think that's right, but I guess, you know, making things better in a relationship or in a family situation generally, as a generalisation, makes things better for everybody. But whether you can automatically assume that treating the man will make the woman better, you know, it really depends on the severity of his depression and how much the depression is impacting on their problems. If the thing that's worrying her is that he's going to die, or that, you know, he's going to be impotent forever, then treating his depression might not help her at all. You have to actually have a conversation with the individuals. And if you only see one partner and the man sees another partner, it's easier if the doctor's in the same practice. I've certainly often had that conversation of, well, would it be okay if I told his doctor that you came to see me? How would you feel about that? At least so that he's aware of your concerns. There's all kinds of issues of confidentiality, but if you lay it out on the table and say, these are some things we could do to help, often they're quite open to that, but I think you have to respect people's wishes in that setting.
Was your wife depressed?
Yes. I think one of the things that we've learnt, and we will pass on as a bit of a testimony to other people, is that if the man is suffering depression, please look at your wife as well, or your carer, because they are dragged down as well. One affects the other. And
did she receive treatment?
Yes, she has received treatment, but she was worse off than I was.
Really?
Yes.
How was it affecting her?
Withdrawal, drawing away from things, not wanting to go anywhere, not driving her car, not wanting to go shopping. It was quite a thing to drag her out of herself. She became very much a homebody, got into a garden, and just wanted to
So while you were off
stay
on your bike in the sunrise, she was in the garden, pottering around.
Just about all burying myself in prostate cancer work, which I...
So you were living parallel existences?
Basically, yes, Norman. And it wasn't very, very good. It's very poor. But it's the one thing that to pass on to people that I don't think enough attention was paid on the problem that would come of this business of depression. Just wasn't. It wasn't in our case. It's only when it was too late, when it was noticed basically in me because of my crankiness, and then suddenly she came down too. And it was, I say it was too late. It should have been picked up way before.
Suzanne?
I agree with all of that. I think carers we need to particularly worry about. There's mixed results on whether carers have more distress than do the patients, but there's certainly enough that suggests that in many cases they do. And I know our experience in running trials at Cancer Council Queensland into psychological interventions for people with cancer, we find carers are relatively difficult to comparatively to recruit into trials because they think they don't really count. So I'm busy looking after my partner who's unwell, etc., and I don't have cancer, so I don't really deserve that level of support, and they can really neglect themselves while they're focusing on trying to support the person who has cancer. So I think when you're looking after someone with cancer, you have to be just as concerned about their partner as you do about that person who actually has cancer.
So Don and his partner's called Glenda, come back to see you, Caroline, a year later. He's had a radical, he's got erectile dysfunction, he's had it for a year, he's got a bit of incontinence. He's been dragged back by Glenda rather than volunteering to come and see you. And she tells him that, you know, he doesn't sleep, he's in a terrible night's sleep, he's not eating well, just doesn't want to get out and about, and she's pretty distressed too, and tells the sort of story that Colin tells. What are you going to do here?
Well, obviously my relapse prevention strategy from the first part of this case didn't work so well.
You don't need to beat yourself up.
I'll say to him, gee, I did tell you if the symptoms came back, you should come and talk to me, and it's great that you're here now. Look, I mean, clearly that sounds like he has the symptoms of depression, but I would complete a more thorough assessment, you know, to...
Oh, you go into full mode.
Yeah, I'd go ask all the questions, and, you know, I mean, I think, there's obviously a list of symptoms you have to qualify for a DSM diagnosis of depression, but we all know in general practice that we tend to think more dimensionally than categorically. If people have got distress and it's of a sufficient level, we usually then start talking about more proactive treatment. And in his case, again, I'd come back to what's worked before, and I would say that if he has symptoms of depression, then treatments that have helped him in the past should help him again, even though the circumstances have changed. These treatments work for the symptoms even if you've got another diagnosis, but you have to be aware that obviously medications have side effects, and he would revisit those side effects if he's had them in the past.
And Suzanne, there's this notion of stepped care that, you know, you talk about the pyramid.
Certainly. We have developed in Queensland a tiered model of care that's been widely used across the country, really. And the essence of this is to acknowledge the fact that while we're talking tonight particularly about the more extreme case of depression and anxiety, most people will get well and do well over time without in-depth, sort of deeper psychological care. So if you think of your pyramid as at the bottom of the pyramid is where most people are, and what they need is good effective communication from their clinicians, to have access to support groups and cancer helplines that the Cancer Council Australia runs, all those sorts of things, to know that there's a Peter around if there in fact is one, to have a supportive GP. That's what most people need, and that will get them through good information.
Just show, you've got a booklet, haven't you?
We've produced several. There's a Beyond Blue booklet we've contributed to that's a general wellness book. Sexuality After Prostate Cancer Treatment booklet we developed that's on the Andrology Australia website. There are actually lots of resources, and Beyond Blue have a stack of them as well, and cancer councils have them. So there's actually an excellent array of resources around the helplines. Cancer helplines are national service. But then if you've got someone who's, say, got mild to moderate distress, they're further up the pyramid. They're a smaller number of people, and they need care which has a deeper but narrower focus. So they might need a psychoeducational program.
What do you mean by psychoeducational program?
Teaching people in depth about what a diagnosis of cancer means psychologically and how you can cope with that. Stress management skills, coping skills training, things you can do easily in a group. Moving up further up, you might want to do relationship or family therapy, and then right up the top of the pyramid are your really vulnerable, highly distressed people who might be suicidal or just demonstrating really high levels of distress, and they might need a psychiatrist, mental health care team, that kind of, you don't muck around with those people who are really in trouble. You get them straight up to that really serious in-depth care.
And if you're in a country town and the referral sources are limited, what's your view of the self-help areas, such as, I mean, we now have, St Vincent's Hospital in Sydney has internet-based therapy where they will actually offer a therapist online, so it's not just you're doing internet-based CBT, the therapist will actually talk to you, a psychologist will talk to you. There's Mood Gym at the Australian National University, Swinburne has a thing. They seem to have very good randomised controlled trial evidence that they work. Would you refer somebody with cancer to one of those?
Look, I think so. If it was a reputable one and I knew about it, it's an emerging area, and it's important for Australia because we have a decentralised population. So these remote access therapies are very important for us if we're going to get population-based translation of psychological care, not just for cancer but in every area. And there is randomised control evidence for these therapies being able to deliver through the internet and on the telephone. So I guess for a GP, it's knowing what your arsenal is. Here I am in wherever I live, and I know that these things are available on the internet and this is available on the telephone.
Of course, this age group, it doesn't necessarily have access to the internet. That's
an issue, and I think that's a problem. But I also think that, again, it depends upon the level of distress. We're doing a trial in this right at the moment where we're offering two different types of remote access telephone-based therapies, and our hypotheses are that the people who are over 4 on the distress thermometer but not right up there around 8 are probably going to do well with the minimal telephone-based intervention, where the more distressed people will need the higher level. That study hasn't been done in cancer before, and we're just waiting the results of that.
Is there any evidence that the response to therapy is different when you've got cancers underlying the depression?
What I'm familiar with is the cancer psycho-oncology literature, where there's good evidence to support a range of cognitive-based therapies, problem-solving therapy. Probably one of the best studies was one that was done on problem-solving therapy, where they specifically targeted people who already had sort of caseness for anxiety and depression. So it's all also about health economics in a way. It's like we've got a limited number of resources. Let's get our in-depth resources and let's really throw those at the people who are in trouble, and then a lot of the others will do just fine with good standard care and access to self-management materials.
Because you feel disempowered, don't you, Colin?
Yes, you do a little. Feel very disempowered. And I feel sorry for the country people too, because they would be even more disempowered than we are, because they have no access to people like yourselves. They're sort of locked away. For them to come into the city takes them a week, you know, and who's going to do that? There's a lot of men that we've heard of who have had reoccurrence of their prostate cancer coming back and it's metastasised too late. Now, if somebody had been in contact with them regularly, probably their own GP, maybe that would not have happened, because they don't have time to go for a PSA test.
Let's have a look at our next case study, which is actually a film study on the Prostate Cancer Support Group, which was created some years ago by David and Pam Sando. And it's based at the Sydney Adventist Hospital in the northern suburbs of Sydney, and offers a unique support base to men and their partners with prostate cancer.
The effect of being diagnosed with prostate cancer varies between individuals and couples. I opted for the radical prostatectomy, and once I got over the original diagnosis, yes, I was anxious, but together as a couple we've been able to handle it. But there are other couples that are not so lucky as Pam and I, and they're the people that we're really trying to look after.
Some guys are still in tunnel vision for a long time after getting their diagnosis, and they don't want to speak about what can happen to them in their treatment options. So it's usually the wife that has this huge learning curve and knows more about the disease than the partner does. We need to know if there's a situation where that woman needs extra assistance, because she's probably got anxiety and depression herself rather than just the male with his recent diagnosis.
It's easy to talk to people that have been similarly diagnosed, and through the support group we can match people up with whatever they're going through. I can think of one couple who came to us in some despair because they weren't communicating with one another, and he didn't talk about it at work, and when he came home he didn't talk about it. But somehow or other they came to our support group, and we gave them some facts, we gave them some connections to medical professionals that could help them, and now they're a great couple that help telephone counsel mainly other people who are going through a similar situation. Beyond blue information about anxiety and depression, the women you can see going through it, and they'll take the fact sheets, and they're the ones, as Pam is suggesting, they're the ones that'll work through things in a realistic way, because mostly they're the health managers of the family, we find, and we get to men through women.
It's amazing how many times, and we were exactly the same, when we found out, you know, prostate, what's that, where is it, what's it do? So it's not like women that they know they've got all the different sexual parts to them. Men think as long as their penis is functioning correctly and they're having great sex, that's all there is to the anatomy of it. They need to speak to their partner and talk to other men if they're brave enough to find out, you know, how they can best move forward.
My erectile function and urinary functions are recovered pretty well, I'd say to 90% to 100%.
It's good to be able to express yourself as well in front of people. As you can see there today, you can be very open and talk about anything at all. But I enjoy coming, there's fellowship, and my wife's been able to come along as well, so she's enjoyed coming along. And I like to spread the word also. I swim every morning and I have a pamphlets in my bag. And if I see a new guy in the dressing room, I say, you'd like to read this? Because there's so many ignorant people out there about prostate cancer.
The advice I'd give medical professionals giving information to their patients about mental health is that they've got to be mindful of the anxiety and the state of depression that people get in when they don't, for instance, have full sexual rehabilitation. They've got to think beyond the diagnosis and the treatment of the disease in the sort of crudest form and think more about getting the person back to a normal way of life, or as normal as possible. And now more and more people are being aware of anxiety and depression and how it affects the family.
David and Pam Sando at the SAN in Sydney. It's not for everybody though, is it, Colin?
What, support groups?
Yes.
Probably not. Probably not. A lot of people prefer to have, I suppose you could say, one-to-one home treatment. That happens on a few occasions, but generally with a support group, it's the man and the woman who comes in. You get the pair of them together.
The man being dragged with his heels skidding on the ground, sort of.
Just about, yes. It's humorous, but yes.
How long does it take on average for the man to sort of, the light to go on?
Light to go on, what, into getting something done?
We're realising that, you know, I don't need to actually resist coming. This is actually not for wimps. It's actually something that's quite good for me.
Some of the people we've had, it's usually a year before they really get involved with a support group. They've been,
really?
Yes, as long as that. A lot of them don't come straight away, but some of them do. They come beforehand.
Which is what you did.
They're seeking. Yes, a lot of the guys who are keen on themselves, they come beforehand, before any procedure is done, and that's where they get the roadmap from.
Peter, do you think the support, you know, what are the limits of support groups? What, you know, the benefits and the limits?
Well, the benefits are enormous, I think, and I certainly have talked at a few of these support groups. The first thing that I did was walk in and I saw how many partners there were. So, you know, there was 20 men and 20 women at the one I saw in Bendigo, and it was a terrific social event as well as education. So I think it's fantastic. But I agree that not every guy will want to turn up to that, and therefore we have to have...
Which is not necessarily a problem, it's just it means a different way of dealing with that man.
That's a bloke, I suppose.
Yeah.
Men are like that. They can be, you know, slow and with, you know, withdrawn, and particularly if you're a little depressed, they don't want to go out and be in public. So, so I think we have to have our door open to give consults and give them time to be able to talk. Sometimes I think they may benefit from talking to the guy, you know, that's sitting on the bar stool next to them. May not give them great medical information, but they need to have somewhere to chat, and that can grow through the clinician if we give them a little bit more time, and then maybe they will join the support group even if it takes a year.
And how do you find a support group in your area, Colin?
It's reasonably active. We've got something like 70 couples registered, and we get a floating attendance.
Yes, but that's in yours in Sydney. But if you're, you know, in Kalgoorlie or you know, the Northern Territory, how do you know where there's? Is there a network of these support groups?
The network of support groups is done from the Prostate Cancer Foundation of Australia.
So you can go to their website.
They have published a list of where the support groups are.
Any evidence, Suzanne, that they work beyond the anecdotal?
There, and actually we've done a lot of this research ourselves, quite a lot of descriptive studies which are cross-sectional, looking at people who go to support groups, what, you know, how are they doing and what are the aspects of support groups that they appreciate, and they've been some very positive studies. I think the important thing is that there are a range of services available and different things suit different people.
A menu.
A menu of different things, which might be the cancer helpline or the cancer counselling service or the support group or one of the volunteers from the support group who's available just to talk on the telephone individually and more anonymously, your GP, your men's health practitioner, and people need to know that some things might not suit you, but don't give up. Give it a try. If it doesn't seem like it's the right form of support for you, let's try something else.
Can I say that in Bendigo we run men's health nights, and we have for 9 years. We get 1,500 men out in Bendigo. Bendigo's a 100,000 population, and we'll go out into the sticks and run these nights. You know, populations of towns that have 200 or 300 people, and you'll get 100 turn up. And at those, even though it may not be specifically on prostate cancer, we will get guys that will come in and sneak in the back, and we'll talk about, you know, things like mental health and sexual health, And those guys will start to absorb that information, and that's what
It's
might
incredible.
guide them. So men's health nights
So
are
much
very
for
successful.
blokes not wanting to come forward.
Yeah, particularly
Give
if
them the
you,
right environment, they will.
particularly if you put on a barbecue and you know, something
Few
to have a
beers.
drink, then
Yeah,
they'll
yeah.
turn up, and you can really talk quite frankly to them.
Thank you all very much indeed. What are your takeaway messages for people watching, Colin?
Takeaway message for people watching is to look at getting a proper roadmap of where you're going, with some of these things that we've mentioned tonight included in that. Of course, the big one being depression.
Peter?
For clinicians to ask the questions to the patients, and then to give them time and to listen to them.
Caroline?
Yes, I agree with that, and to believe in yourself that you can make a difference by being engaged in helping people with psychological problems as well as physical ones.
As indeed you can. The evidence base is there. Suzanne?
Cancer is a major life stress for both the person with cancer and the carer, so good psychosocial and psychological care is central to good care.
Thank you all very much indeed, and thank you. I hope you've enjoyed the programme tonight on maintaining well-being, depression and anxiety in men with prostate cancer. Our thanks to Beyond Blue, the National Depression Initiative, and the Prostate Cancer Foundation of Australia for making the programme possible. But thanks also to you for taking the time to attend and contribute. If you're interested in obtaining more information about the issues raised in the programme, there are a number of resources available on the Rural Health Education Foundation website, rhef.com.au. To register for CPD points, don't forget to complete and send in your evaluation forms. I'm Norman Swan. I'll see you next time. The next Rural Health